started. And from there, we're going to go ahead and get started. So I'm excited to have Dr. Owusu with us. He is an orthopedic surgeon who did a sports medicine fellowship at the Hospital of Special Surgeries in New York. He attended Duke University School of Medicine for medical school and residency. And even let's go a little bit further back, he also went there for undergrad as well. So he's a lifetime Dookie, which is strange now that I'm a Tar Heel who also am a Dookie. So that's just weird. I don't know what to say anymore. But a cool fun fact about him was that he was the assistant team physician for the Brooklyn Nets during the 2019-2020 basketball season. And we are excited to have you with us. So thank you again for joining us tonight. We appreciate you.
Oh yeah, Dr. Weiss, thanks for having me on. I'm gonna hop in here. Congrats to those of y'all who voted today.
Yes, we got it done, and we'll see what shakes out. But everybody did their civic duty. Congrats, kudos to you.
Indeed.
All right, so.
All right, so we have a video here. This is kind of an old clip, but let's take a look.
Pass, falls down, lost the ball. Thompson running the floor, and a foul. And Thompson grabs his left knee, now writhing in pain. Steph Curry slamming the ball on the court, so up.
All right, kind of an old clip. Those of you who watch the NBA are familiar with that. Who can tell me what this injury was? Anybody remember?
You guys can unmute yourselves too.
You can throw in the chat, a knee injury. Okay, good start. Anything more specific? Tendon tear? Good. Which tendon? ACL. Yeah, that's right. It was an ACL. A few of y'all got it right already. That's right. So that was an ACL tear. And as many of you know who may watch the NBA, they kind of took Klay Thompson out of the game for, over a year. So these are really devastating injuries to the knee, and one of the more common ones that athletes sustain. So it's one of the more common surgeries that I perform. And we're going to kind of get into what all goes into getting somebody back to playing sports again after an ACL later on, right? So today we're going to talk about, what it means to be an orthopedic surgeon, specifically an orthopedic sports surgeon like myself. We'll talk about the anatomy of the parts to make up the knee, and we'll learn about the anterior cruciate ligament, or the ACL specifically, with it being one of the more common knee injuries that we're seeing out here.
All right, so we're going to jump in first and learn a little bit more about you and ask you to share a bit about your story. So, I've known you for a long time, but I want the audience to get to know you more. And first question we really like to ask is if you could just share a little bit about what an orthopedic surgeon is and what inspired you to go into the field of orthopedic surgery.
Oh yeah, for sure. So orthopedic surgeons deal with treating injury to the bones and joints of the body. So that's, it could be knee, shoulder, the back, the feet, anything along those lines. And so we're doing oftentimes surgery, but sometimes people don't need surgery, and we're treating them with other things like physical therapy or injections or medication. So orthopedic surgery really is concerned with people's movement, which is something I'm very passionate about, because I see movement as freedom, and making sure everyone can move like they need to and want to is an important thing to me. Specifically about sports medicine, sports is so important to so many different people. It's important to people's livelihood, to scholarship, or even just leisure or mental health. And so being able to put people back in a position where they can play the sports or do the activities they love is really important to me.
Fantastic. And so, along your journey of kind of figuring out you wanted to do orthopedic surgery with a focus in sports medicine, what challenges did you face along this journey?
Well, I'd say probably the biggest challenge is how long the journey is. So you're looking at 4 years of college, right? 4 years in medical school. That's when me and Dr. Weiss were kicking it, hanging out. You're looking at 5 years of a residency. Many of y'all may know, but a residency in medicine is where after you finish medical school, you act as sort of almost a junior doctor underneath someone else's tutelage, someone's teaching. And so in that setting, you're a doctor, so you're not in school, but you're not really completely independent. You're still learning. So that residency is 5 years. And then I did an extra year of training in sports medicine in New York, like Dr. Weiss was saying. Since then, I've been in Richmond, Virginia, doing my own practice, taking care of athletes in this area. But the biggest challenge is the length of time to get through to being an orthopedic surgeon. So as an undergraduate student, I mean, it feels like it was yesterday, even though it was, over a decade ago.
Right.
Things like getting through organic chemistry and balancing the biology and the physics and the math and all those classes you're trying to take while still trying to live, a modicum of a normal life, trying to take care of your responsibilities, hold down the job, what have you. The time management is probably the biggest challenge. And, as you go along, you'll see that time management, that doesn't go away as a problem. That's a problem, that I deal with now, that people my age deal with right now. So really, those of you in undergrad, this is a great time to set those habits. They're going to serve you for the rest of your life.
Absolutely. Absolutely. And when you talk about the length of the journey, can you share a little bit about, residency is long and hard. So, can you talk about your first year of residency and how you kind of progressed through residency after medical school?
Yeah. So when you finish medical school, you're a doctor, but you really only have book knowledge. You don't have a whole lot of practical day-to-day knowledge. So the goal of your residency is to make you someone who can actually take care of people. So the first year of an orthopedic surgery residency, you're really just learning the basics of how to be a doctor, how to take care of patients who are in the hospital and kind of sick. As you move along your journey, you're getting more and more introduced to orthopedic surgery itself. So you start off going into surgery or the operating room and kind of observing other people do surgery. And then as you learn more and more, you start to do the surgeries. And so by the time you get to year 4 and 5, it's really you doing the surgery and then your mentor kind of talking you through it or telling you where you might want to do something different or this and that. And the expectation is by the end of year 5, really, you could do the surgery yourself. Your mentor can go stand in the corner and watch you and make sure everything's okay, but you're handling the business. And that's kind of the progression of how it goes.
Yeah, absolutely. I think that's important to know because with every field, it's a little bit different, especially as a resident. And so to hear that first, you got to get the patient care knowledge down. And are you really focused on the hospital side of the recovery for your surgical patients at that point?
Exactly. So your main learning point, the main thing you're responsible for in the beginning is taking care of people after surgery that maybe some older residents or the mentor physicians are performing, and you're helping take care of them afterwards. So that way, once you learn to do the surgeries yourself, you know exactly what it takes to go into taking care of somebody after surgery, which is crucial.
Mm-hmm. Absolutely. And so when you think about the challenges, I want to think a little bit about what are some of the joys of your job that you have now?
Well, there's a lot. I would say the number one joy is seeing, somebody who got injured playing a sport or doing an activity or something like that, seeing them graduate out of my care and going back to play sports. Probably the biggest thing that I love is when my patients text me pictures of them back in their football uniform or their basketball uniform, or show me a video of them tackling somebody after they had an ACL. It doesn't get any better than that. So seeing that really, really brings me a lot of joy.
Fantastic. And can you share a little bit more about, what characteristics do you think students should think about if they want to pursue orthopedic surgery?
Oh, yeah, for sure. So we talked about time management some earlier. I think time management is the biggest thing. And what does that come down to? That's, discipline, being able to, kind of take a task to completion, or setting yourself up to complete tasks, in a timely manner, which is time management in and of itself. Of course, we need compassion for any physician or doctor. Needs to be able to put yourself in your patient's shoes and really take care of them the way you want yourself or a family member to be treated. And then, there is an aspect of, say, hand-eye coordination that is necessary. You need to be able to successfully use your hands to perform the surgeries. But I mean, that's something that's teachable. I would say that's teachable. The things that are less teachable are things like discipline and compassion. Those are things that you really want to be, I guess, building as you come up throughout your journey or your process.
Absolutely. Absolutely. So that's fantastic. Okay, so we are going to jump into our stethoscope case files, and
Right.
I will let you take it away from here.
All right. So we're going to put you in my position. Y'all going to be the doctors here. You're going to help me walk through taking care of this patient. So Kamara is a 16-year-old female. She plays two sports. She's soccer and basketball. This summer, she was playing a little pickup game and twisted her knee. And let's think about what's wrong.
Drum roll.
So what do y'all think is wrong? We've kind of been talking about it some. Yeah, that was a softball. Okay.
Softball.
We talked about the ACL. Okay. So we think Kamara has an ACL tear. Let me ask you this. When someone first tears their ACL, what do you think it looks like at that time? Like how does that person feel? What does their knee look like? What's kind of happening? I see swelling and tenderness. That's excellent. What else you think? You might have seen this in the first video. It could look out of place. That's a good question. Yeah, that's good. Popping out of place. I've seen that a couple times. Instability, exactly. So, we're going to talk about this in a second. The ACL kind of holds your knee stable, right? So it can't slide back and forth. And so the knee will bend unintentionally and kind of give way. All right. You might have seen that when we saw the video in the beginning where he tried to stand up and kind of fell down. So the knee was unstable. And for a second, the knee does pop out of place, usually coming back into place. But when that happens, that's when the ligament tears. So swelling, instability, seeming like the knee came out of place, tenderness, all these things that are things that you might see when an ACL happens. All right, we can check the next slide. All right, so anytime we're talking about orthopedic surgery, there's special anatomic or anatomy terms that we use to describe it. Just like every field has its own language, anatomy is the language of orthopedic surgery, okay? So there's a few different anatomy terms that we can use. On the left, you'll see kind of the directional terms, okay? So anterior is front. So if you feel like where your kneecaps are, that's anterior, that's the front of your knee, okay? Posterior is the back. If you feel like in the back of your knee where the bend is, that's the back. Proximal is moving up towards your head, and distal is moving down towards your foot, all right? So those are kind of the directional terms we use in orthopedics, so we're all on the same page. So anterior front, posterior back, proximal is top, and distal is bottom. Then over on your right, what you'll see is we talk about different regions of the knee. So the patella is the kneecap. I'm sure many of y'all know this term. The kneecap is the patella. You have the femur. The femur is the thigh bone. And it comes down, and the bottom of the femur meets the top of the tibia or the shin bone. And together they form the knee joint, really form the knee joint. Then the fibula is a small bone right next to your tibia, right next to your shin bone. And it's there kind of adding support, but it's not the main player. The two main players talking about the knee are the femur and the tibia, and then the patella and the fibula are kind of around giving support, all right? There we go, all right. So let's talk about the ACL here. So the ACL is the anterior cruciate ligament, ACL, all right? And it's anterior in that it's sitting in front of another cruciate ligament, which is the PCL, okay? That ACL in the front is trying to stop the tibia or the shin bone from sliding forward. A scary image, yeah, a little bit. Seeing somebody's knee slide like that is scary. So on the left, that picture of that knee sliding like that, that's kind of what happens when an ACL tears. The shin bone, the tibia slides forward and the bones kind of connect. Oftentimes they get bruised. And then on the right, you can see the ACL there in the front gets torn when that happens. So the ACL is going from anterior, it's going from proximal to distal, all right? And it's sitting anterior, and it's supposed to be holding that tibia in place whenever you're doing anything involving with pivoting or jumping. So let me ask you this question. Is it possible to walk around with your ACL torn?
You guys don't be shy.
Anybody?
You can shout it out. Probably hard. Yes. Got some yeses.
Yeah, it absolutely is. Yeah, you've seen it. So there are a lot of people who initially, of course, they injure it and they fall down, they're unstable, right? But with time, you may see them get up and walk, like even walk off the field. And so it is painful, but it is possible to walk without an ACL that's intact. So the ACL really plays its biggest role if you're trying to pivot, like change direction quickly or jump or really take off sprinting. But in terms of being able to walk in a straight line, you're kind of able to do that with an ACL torn. So it can sometimes fool you when you see someone leave the court or leave the field. It seems like they're walking, but then you hear later, oh, it was an ACL tear. It can be surprising, but that's actually not uncommon. Very good.
That actually happened to Klay Thompson too, right? If you
Right.
remember, he went and shot those free throws. He like walked down and walked back and shot the free throws.
That's right. You don't need an ACL to shoot free throws, but if you're trying to run and jump, you definitely do. Definitely do. All right, we can keep rolling. All right, so here's an example of what it looks like when the ACL is torn. All right. So this person is stepping down and their knees kind of giving way. And what's happening is that ACL there in the middle is tearing when it takes on the force. So a lot of times an ACL tear can happen without you even taking contact from another player. It can be as little as just landing in an awkward position with the knee. And that's kind of what happened to Klay in that video. He was kind of doing his own thing, hit the leg awkwardly. He hit it just wrong. And the ACL takes all that force and then it tears right in the middle. So here we go again. So I guess it's being kind of slow there.
Uh-oh. So if you guys notice, you can see him like rising up to jump and shoot and twist and things.
Exactly. So what's happening is, sorry, the video is a little bit jumbled there, but the idea is that, it doesn't really take somebody hitting you or hitting your knee. It can be as much as you just landing awkwardly in a way that your knee is not expecting. And then suddenly, your knee gives way and there it is. Okay. All right. So, we have someone, Kamara is our girl we're talking about, our athlete. All right. How do we find out that she really has an ACL tear? I mean, we kind of think maybe it happened because she fell down, her knee's swollen, it's unstable, she kind of wobbled. But what do we need to know for sure she has an ACL so we can treat her properly? Lack of stability. Okay, that's very good. Yeah, so that's a good point. So the first thing that happens with any patient is that we do a physical exam, okay? So we take a look at the knee, we see if they can bend, and we perform someone wrote a Lockman exam. Someone's next level. Yeah. So a Lockman exam is when you take somebody's knee, you can see my hands, and you pull on the tibia, and you see if it moves forward, all right? If it moves forward too much, we know that the ACL is torn because it's not holding it in place. So that's a Lockman exam. Being able to not bear weight, that's another good point. Yeah, just like we talked about. So you're checking knee stability on the physical exam when you're putting your hands on the patient and testing the knee and seeing how much it bends, seeing if it's stable. What about anything else? Like imaging? Any imaging studies you might look at? Excuse me. CT scan. That's a good thought. We don't typically have to do a CT scan for this injury, but it is a very important one. I see x-rays and I see MRI. All right, someone tell me the difference between an x-ray and an MRI.
You guys are quiet tonight.
X-ray checks bones. There you go. Victoria's got it. So an x-ray is good for checking the bones and not much else. It's not going to show you the soft tissue like the ligaments or the cartilage. Things like the ACL will not show up on an x-ray. That's MRI checks. I'm on point. MRI checks soft tissue. So in a situation like this, we usually end up getting an x-ray to make sure she didn't break a bone because that's also a possibility. Mm-hmm. If she didn't break a bone and we're worried about a soft tissue injury, for instance, an ACL, then the next thing we do would be to get an MRI to check the soft tissue, to check that ACL. Very good. All right, we'll go to the next slide, I think.
Mhm. Our slides are taking their time tonight.
That's all right. All right, so we're looking over on the right side there, okay? And the video is kind of scrolling through. We're looking at the knee from a side view, all right? So you can see the kneecap in the front. It's being kind of slow, huh?
Mm-hmm. It's all right. We can see it in pretty much real time now.
All right, we'll look on the one on the left there. All right. So there in the back, that's the PCL. It's a nice thick black line. In front of it's the ACL, and it's not doing the same thing. It's kind of a big jumbled mess. All right. So when we see that, we're thinking that's the ACL tear. Now that's a normal ACL. That's how it's supposed to look. And so you may have seen the difference. We'll go back through it one more time. It looks like it's going through one more time here. So they mentioned anterior tibial translation. That's exactly a good point. So we're looking at the tibia compared to the femur. If it's moved anterior or forward, then we're worried about the ACL being torn. I'll tell you what, Dr. Wise, let's start the video at the beginning.
Okay.
To see that important part one more time.
Excellent. Okay. Okay, there we go. It's scrolling through.
Oh, here it goes. Okay, so going through side view of the knee. Now we're in the middle of the knee. So the red pointer is pointing out the ACL, how it looks like a big jumbled mess, as opposed to a nice clean black line. So behind it there, that's the PCL, posterior cruciate ligament, looking perfect, looking good. Lumostats line is a line we look at when we're evaluating the knee to kind of see what the angles look like. And that gives us a good look. And then there's the ACL like it should look. So you see the big difference between what that looks like and what the torn ACL looks like right there.
Mm-hmm.
Good. All right, nice video. All right, we can go to the next slide, I think.
All right.
All right, so when someone has torn ACL, what can we do to treat them? What's the next move? Rehab, very good. Rehab is an excellent option. Surgery a couple times. Surgery and rehab, those are the two biggest options.
Mm-hmm.
So remember I told y'all, you don't need an ACL to walk, right? PT, yeah, very good. So you don't need an ACL to walk, right? So do you think it's possible for someone who doesn't play sports or doesn't cut or pivot or run to go on with their ACL torn and not have surgery? Absolutely, yes. Yep, you got it. So if someone tells me my hobby is to do knitting or my hobby is to hang out and not even play basketball or anything like that, then you absolutely can do rehab and not do surgery. It will be uncomfortable in the beginning. Salisha's absolutely right. But if you don't do any pivoting activity, if you don't move around, you can do some physical therapy to strengthen the muscles around the knee, and that can be enough for you. Now, if you go off, when you try to make a cut, try to jump, try to change positions quickly, you may feel your knees go unstable again, all right? So if you're planning to do that, anything like that, it's probably best to have surgery for the ACL. So that's how that's possible. I saw a question about tendonitis becoming a full tear. It is possible for tendonitis to go on to become a full tear. That usually happens in kind of older people. That's a big question for people who are like over 40, where you might have a tendonitis, not even at the ACL and any other tendon in your body that goes on and tears from being inflamed before, okay? That's a great question. But in a lot of people who are like our patient's age, a 16-year-old, we're gonna recommend surgery to fix the ACL because for one thing, she wants to keep playing sports. She's a young athlete. The second thing is if you try to play sports and you have your ACL torn, you have a much higher risk, of tearing something else inside your knee, like tearing another ligament or tearing the cartilage or tearing the meniscus, which is like a shock absorber inside of the knee. And you don't want that to happen. So for this patient, I think surgery is the best option.